Hello everyone, I'm Sung-Hae from Shizuoka, Japan. I'd like to present a case about staged PA rehabilitation. My disclosures are as follows. At first, this case was diagnosed prenatally as etiology of Fallot with MAPCAs and right aortic arch. She was born in a hospital at gestational age 39 weeks with relatively low birth weight, and the saturation was 95%. Initial echo showed 6 to 7 mm perimembranous VSD with outlet extension and 50% aortic valve overriding. And the pulmonic valve was 3.7 mm in diameter, 49% of normal size, and its Z-score was minus 5.8. It was bicuspid with severe doming, and its opening was less than 1 mm, and with PR, and the outlet septum was very small. You can see retrograde flow in both pulmonary artery branches from distal side. And we found right aortic arch and MAPCAs and secondum ASD with left-right shunting. She gained body weight and PS velocity on echo with some diuretics until and over 1 month old, and underwent CT scan at the age of 29 days. The CT scan showed 2 MAPCAs in the right and 1 MAPCA in the left, and suspicious small PDA from left brachiocephalic artery with right aortic arch. Once she discharged home with nice balance of saturation at the age of 37 days. At the age of 48 days, she admitted to a hospital again with 78 saturation, and the diuretics was changed into beta blocker. At this moment, we thought that we had to do something, and this is the problem list. She was 1 month old, 3.9 kilograms. Her P-valve annulus was very small, less than half of normal, and bilateral PAs were confluent, and PA index was 123 by echo, perimembranous VSD with tiny outlet septum, and 3 MAPCAs and probable small PDA. And these are the options. The first is BTA shunt only, and the second, unifocalization and BT shunt, and the third is unifocalization and definitive repair, in other words, one-stage definitive repair, and the fourth is P-valve ballooning with or without MAPCA closure, and the fifth is PDA stenting with or without MAPCA closure, and the sixth is PA ballooning and PDA stenting with or without MAPCA closure, and the seventh is RVOT stenting with or without MAPCA closure. I wonder which you like best, and our option, we choose the last one. At the age of 61 days, we brought this baby to the cath lab. And we found negative contrast in bilateral distal pulmonary arteries, and PA valve annulus was 4 mm in diameter, and the PA index was 154. It was almost identical to the echo findings. This is the MAPCA1, which supplied to the central right pulmonary artery. And this is the MAPCA2 supplied to the central left pulmonary artery. And the suspected small PDA or small MAPCA with some connection to the left pulmonary artery. At first, we closed the small PDA with 2 microcoils and dilated her P-valve with 5 mm balloon. These resulted in some gain in saturation up to 85%. Then we closed MAPCA 2 in the left using 4 mm Amplatzer vascular plug 2, and her saturation was 82%. Then we performed test occlusion of MAPCA 1 with a multi-purpose catheter in the right, and that resulted in the saturation drop into 72%. So we confirmed only balloon into the P-valve was not adequate to provide pulmonary artery forward flow. So we put a 60 mm stent in the RVOT and P-valve. After that, we closed the right MAPCA using 3 mm flipper coil. Her final saturation was 93% in room air, and she discharged home again. The echo showed perfect position of the stent with forward velocity 4.2 meters per second and free PR. The proximal edge of the stent was just at the small outlet septum and no AR. At the age of 4 months, she came back to a hospital for second catheterization. 3D rotational angio of pulmonary artery showed almost no peripheral branching, and we counted at least 16 lung segments. We found distortion in LPA bifurcation, and bilateral lung scan was well balanced. And the PAs were well grown with PA index 352 without pulmonary hypertension. And we underwent residual MAPCA closure and confirmed the coronary artery pattern and corner branch by selective angio. And our surgeon performed definitive repair, including stent removal at the age of 6 months. Her post-operative course was very good and discharged 15 days after the surgery. Our surgeons told us that the most challenging point was removal of the stent. It was a balloon expandable stainless steel stent with semi-open cells, 40 mm in length. They opened the RVOT with longitudinal incision, and the stent appeared. At that moment, 38 days had passed after stent implantation. It was highly endothelialized like this, and adhesion to the septum was sliced by a scalpel with ultimate caution to the aortic valve on the opposite side. In summary, RVOT stenting and MAPCA closures enhanced PA forward flow. This strategy is feasible and resulted in achievement of definitive repair, skipping the process of unifocalization. Since 2014, we have reported the efficacy of modest-sized ballooning to the pulmonary valve with tetralogy of Fallot and related diseases. This initial palliation replaces BT shunt for neonates and early infants with deep cyanosis. But it is limited in the cases of subarterial doubly committed VSDs, which is frequently seen in Asian population. And the ballooning is also an ideal first palliation for PA growth in the cases with MAPCAs. We reported competing MAPCAs need serial transcatheter closures until achieving definitive repair. And the particular case in this presentation also published as a brief report last year. 감사합니다.